Reagan's on our board. Carolyn is the person who got her daughter to DrFowlkes and started everything out at DrFowlkes. So raise your hand, Carolyn. Raise your hand. There she is. So Carolyn is sort of going to be our mentor tonight. And why? Okay. Sorry, I had a big thing across my screen and I couldn't see the top row of my people. So she's going to answer a lot of questions. And the reason that I know a lot of people were trying to post in the group questions or anything about DrFowlkes, and I just put his name on there as a thing. So if you were trying to post something about DrFowlkes this week and you couldn't, that's because his name was banned from the group until we had this meeting, because I just wanted to try to let us get things settled so that we could talk about what was going on, and then people could start posting again, because there was a lot of problems like I can't get a meeting, I'm having problems with an appointment, blah blah blah. And so I wanted us to all try and get things talked out so that maybe we can be intermediaries between his office and us and try to help everybody, get things smoothed out so that appointments go better and the office knows that you guys are having problems, and maybe Carolyn can help with some of the problems that are going on too. But I did talk to DrFowlkes as well, and he wanted everyone to know that, he's doing his best, but they had a surgeon leave, and
Mm.
you know he has somebody else, another surgeon that had cancer, and they're
Oh.
going through chemo and everything. And so some days when he's supposed to be doing appointments with everybody, he has
Everyone
been
else's
called
work.
out. And so, he may get way behind, but he's still trying to make those appointments with you. And it's he's doing the best that he can, and he's trying to fit everybody in, and he knows how important this is, not only for you all but for him, because he sees how great this surgery is for the patients that he's already done. He's done 11 surgeries so far, and he thinks that everybody's doing really well. So he is doing his best on his end to help everybody as quickly as possible. And when you try to do that, sometimes things fall through the cracks. And I said to him, you know, you could easily make it harder for the patients by making them come to the office and do an in-office visit. And he's like, I don't want to do that, because I know that that's going to slow down the process for getting people to surgery. So you all have to understand that he's trying to make it easier by doing virtual appointments, because he knows that some days he has to cancel an appointment. And if he had to cancel an appointment after you've already flown there or driven there, then what's going to happen?
I have to say the online appointments with my neuro GI have been, well, he's now back in Pittsburgh, but he was an hour away, but it's been life changing. Like he's like, I don't want you coming into my office. Like, let me just call you. And after experiencing what I experienced this weekend and getting sick, like I totally see what they mean. And if they offer, and this is just my advice, if they offer in like a video call first, always take it because that puts you on their list too.
Right.
And they're
And I
trying to get you in. Don't make that think, oh, they're just pushing me to the side because I know that feels like that sometimes, but that's actually them trying to get you in.
and I
And
think that some
Carolyn
I
again? I'm sorry.
hmm,
Who is Carolyn again?
Carolyn.
Hi. I just
That's
didn't meet
me.
you the first time. Nice to meet you.
You too.
Well, and I think that Reagan, you butted in, and now I forgot what I was going to say.
I'm
But
sorry.
but I think that sometimes, even if, like, you get delayed, or your appointment gets pushed back, it's much better than, you know, waiting to get an in-office appointment, because an in-office appointment is going to be, I think, months down the line.
Mhm.
Right, Carolyn?
That's absolutely true. I think what people need to realize, it's not like going to the Cleveland Clinic or going to UPMC or something. I mean, this is not a medical center, so they're not used to people coming from out of town, and their priority is to the people in the community. Um, and he's the trauma surgeon and chief of surgery, and that's his hat he wears. So he's, to be flooded with a lot of people from out of the area is a lot of strain on the hospital right now. So he's doing the best he can, but he can't do this full time, unless he wants to, start his own practice with that. So it's kind of, it's just he's fitting people in.
Well, he's not fitting them in. He's putting them, probably missing out on his home life
Yes,
and everything
that's
else,
true.
because he's doing this after he's done his work all day, his office hours and everything else.
Hmm.
And so Wednesday and Thursday are his office hours, and he's doing this after he's done his full day of work at the office, gone to the hospital and everything else. And then he's putting you guys in at
What?
way at the end of the day.
Yeah, you can go. I think I'm just watching some.
So that's where this is going. So, okay, let's see. Do we have questions? Who's up, Tara?
So Carissa is asking if DrFowlkes does virtual appointments for patients in Canada.
Yes. I think yeah, he'll see anybody. You just have to get your records to him, and then they look at your insurance or how you're going to pay, right, Carolyn?
Right. I mean, that would be the thing, is how is that going to work for payment? I mean, the hospital would have to figure that out, I guess.
And then her other question was what his surgery is, and it's Dr. Alviar's duodenal
Derotation.
derotation with duodenodudenostomy. Um, but her question is it open or laparoscopic?
It's an
Anna,
open. Oh, is
yeah,
Anna here?
Anna,
Yeah, Anna can
Anna, you
tell
want
you.
to tell?
It's a open procedure, but the incision is only like 3 inches long for patients who haven't had previous open abdominal surgery.
And tell them where it is, Anna.
It's in the upper right quadrant.
Oh, that's
Horizontal.
awesome.
Yeah.
It's not a
That's really
vertical midline incision.
That's awesome. How are you feeling, Anna?
I am eating totally normal. Feeling
Good.
pretty much normal now.
That's
I'm
awesome. I'm glad
like
to hear
7 months post-op.
You go, girl. Good job.
Thank you.
And then Gracie is asking, she says, DrFowlkes has done 11 surgeries. How many of those were Dr. Alviar present, and how many were done with just DrFowlkes?
He did. Let me think about that. 1, 2, 3, 4. I think he's done 5 with Dr. Alviar. Most of the, maybe 6. Most of those were the ones he did with Dr. Alviar. Was he did the first double malls SMAS, and he did a couple of revisions with him as well, like DJ revisions, and another patient that was fairly complex, had some complexities. So those are the ones he's done, but I think it's been about 5.
And see, that is one of the great things about Dr. Alviar's procedure is it does allow a reversal revision of the DJ surgery. So, and I don't know how many participants really know exactly what the surgery entails. So if you guys need an explanation of what it is, just type it in the chat or shout out, whatever works. And then Monty's asking, Anna, what was your recovery time, or are you still recovering?
So I started on a clear liquid diet in the hospital full liquids when I got home. At my 10-day appointment, he said to advance my diet as I tolerate it. So I started on some very soft foods after that, and at about 2.5 months, I could eat most things, excepting like raw veggies and red meat, which I slowly introduced in very small amounts after that. And now I'm 7 months post-op and I can eat pretty much normal. I would not say I'm still recovering. Occasionally I have some like gas pain, but that's about it.
Yeah, and I would say she had a pretty fast recovery. I mean, she was out of there in 5 days, and you don't remember, but remember when you went to McDonald's with your brother like 2 weeks later? I mean,
That was
like,
actually 2 months. I was at 2 months.
okay, what's it? Okay, never mind. So part of the recovery is that she had, she had been eating, meaning like she didn't have tubes at the time of her surgery. She had them taken out like a few months before. She'd had them in for like 8 months. We took them out. They closed up, and then her SMAS returned. So we were desperate to get the surgery before she lost the weight she had from the tube. So she was going in at a good weight because of the tube feeds, but she was only able to get about 600 to 800 calories a day in of, boost or whatever. But she was using her gut before she went in, which I think made the recovery quicker. Um, because, I think if you haven't been using your gut, first of all, you have to reestablish the biome in, your gut biome. And, you know, it's a muscle. So if it hasn't been used, it's going to take a long time to come back. Um, she was like the first month she was lactose intolerant. I mean, that was something she hadn't been before. And the dietitian said whenever your duodenum is inflamed, that's a pretty common response for that. So it took some time. She said the dietitian just said, don't say you have a bunch of food intolerances, just keep adding them in smaller amounts. And eventually that will hopefully go away. So, and it did.
That's good to know. So, do you think having a nutritionist or helped you out afterward?
Well, we had her before we went in because we were trying desperately to keep whatever weight we could on her before, while we were waiting to get this skirt, the surgery scheduled because the hospital was not sure they were going to allow it, and it was a lot of red tape to jump through. But so we had the dietitian. She was trying anything she could to help us, try to optimize the amount we could get her, and we just kept seeing her afterwards because and it's not specific to this bowel surgery, any bowel surgery. It's you're going to have some adjustments to make. It's not going to be quite the same. And it's for what you could tolerate. Like she said, for like the raw vegetables and salads, if you eat something and you have a reaction to it after bowel surgery, people say, okay, I can't tolerate that again. She said, no, just wait, like maybe give it a week and then reintroduce it in like a dollhouse size portion. And then
Right.
just keep doing that little bits. It's because it's not usually the food that you're intolerant to, it's the volume of food that's crashed your system. So just keep, you know, s- adding in a variety of foods. So you're trying to rebuild the gut biome that can actually digest some of those foods. That's what she said anyway.
Oh, that makes sense.
Yeah.
Okay, so before I ask you guys to kind of explain uh the surgery procedure, um looks like Bree had a quick question. How many revision surgeries has Dr. Folks done?
He's
Do we
done
know?
he's done two revisions. That was with Dr. Alviar, and he'll be doing another one in February.
Okay. And then I don't know who's best to kind of explain the procedure.
I mean, I can explain it unless you want to, Stacy. I mean, so basically what he's going to do is he's going to take your duodenum out of the angle, and that's a tricky place to operate. That's why a lot of doctors are hesitant to do that, because you're not just releasing the ligament, you're actually taking the duodenum out. So it's just it's a hard area to access. So that's one of the challenges of it. They're going to take the duodenum out. They're going to rotate it a different direction, a different configuration to get it out from behind where it is and around the pancreas, the head of the pancreas. And then they're going to stabilize it in place. He sutures right at the DJ flexure. And then he also does the anastomosis where he takes the part of the jejunum that's next to it and puts a small hole through it, or anastomosis, that further is going to keep, it's going to keep that duodenum from kinking right at the juncture, which is something that can happen if they don't do something like this. So it's a risk, especially with some people that have EDS. It's a small risk, but it's still there. So I think, I can't remember the statistic of how many he learned this, just based on his watching what happened with some of his surgeries that he'd done long ago. So he now just routinely does that, and that further stabilizes it. So once he's moved that, he moves all of the intestine that's on the left side of the body, the small intestine. He moves it over to the right, and it fixates it, so it's all there. But in order for it to have enough room, he takes the part of the colon that's already on the right side, um, and he moves it up and puts that on the left side and then stabilizes it. And he has to take the appendix off, because if present in the emergency room later and somebody thinks you have an appendicitis, it's not going to, not having it there is going to clear things up. Like it won't be the same. So it's to keep it from if you have a crisis later. And he stabilizes it there. So you're kind of,
Cool.
you're basically in the same configuration as if you were born with congenital malrotation, which is a little freaky, because I mean, this is a pretty major surgery. It's pretty radical. So people will say, oh, we don't want to, other doctors might say, oh, that sounds really, really radical for this. But I think it solves the problem because it's taking it out, and it solves some of the problems that these doctors are seeing with this surgery, where sometimes the intestines don't want to stay where they're put because it's like unwinding a hose. It doesn't want to stay in that configuration. You're putting it in a different place. And so in past people have done this surgery, the intestines sometimes have flipped or kinked on themselves or twisted, and that can be a pretty dangerous situation. So that's why Dr. Alviar stabilizes everything where he's putting it, so that risk will be minimized.
Yeah. Well, and the cool thing with his appendectomy that he does, um, is he inverts it into the colon and then ties it off so that it falls off into the colon. You don't have the risk of the infection. Like if
Although
they were going in to do,
he hasn't been doing that here. He does a
okay,
regular staple. I don't know.
well,
I'm not sure why. So.
we need to pop him upside the head. Um, so Monty, your question was, aside from the scar, how are the two types different, good and bad? And it's kind of like Carolyn just stated, it's rotating the intestine out from underneath that compressed area. With your typical DJ surgery, um, your intestine is still being squished. So you're still going to have that pain unless you are one of those lucky few that can regenerate a fat pad. But keep in mind, a lot of patients probably have never had a fat pad. And so not only that, it allows for the maximum amount of nutritional absorption because you're not cutting out that third and fourth portion of the duodenum versus the DJ surgery. So the DJ surgery, a hole is created just before the compression, and then they bring the jejunum up and suture it together, and they create that hole. So you're losing nutritional absorption. And the first part of your small intestine is where the most nutritional absorption occurs. So that's probably one of the biggest differences. Um, Anything else with that? The good, the bad. Oh, you're at less of a risk of developing SIBO, which is small intestinal bacterial overgrowth. With the DJ surgery, again, that compression remains, but the food can still try and go that natural path, and it can get stuck in that compressed, kinked area and essentially rot within your intestines. And that's going to cause belching, bloating, all kinds of issues with that. Traditional versus robotic lap laser. There's not really any difference. It's just how open, and Dr. Olivier used to do it open, and now they can do it with smaller incisions. Being open allows them to have more room to work and
Well,
less chances of risk.
every doctor has their preference. Like Dr. Showhead does his laparoscopic robotic. However, it takes him 6 hours to do the surgery. Dr. Folks does it in 45 minutes. So there's your difference between laparoscopic robotic and a 3-inch incision.
One of
Now,
the oh, go ahead. Sorry.
oh, go ahead.
No, I was gonna say that, open, there's, pluses and minuses, like you
Right.
said, like the robotic surgery, is cleaner and it produces less adhesions. So if it's somebody that's had a lot of surgeries before, robotic might be a better, something you might want to look at because it produces less and you already have a lot. Every time you have a surgery, you have more and more adhesions. But having anesthesia for a longer time, robotic takes longer, also has risks. So there's risks for that. Now, open surgery, again, there's risks of adhesions. And adhesions, you can't predict where they're going to go, and sometimes, and you can't really, sometimes they will wrap around the small bowel or large bowel or whatever and cause obstructions that can cause problems in the future. I mean, that's a risk of any open abdominal surgery. But there's also something called friendly adhesions, which you kind of want in this case because you're kind of wanting the bowel to stick where you put it because you don't want it to be flipping or twisting or doing anything weird. So adhesions can help in that case, and so there's sort of a trade-off on that.
There is a medication that they can use during the surgery that helps to prevent adhesions. I'm not sure what it,
Septifilm, yeah,
huh,
they can use septifilm, but there again, it's like it's some people say it doesn't do what it's supposed to do, but
but the other thing about a robotic laparoscopic surgery is people with EDS who are on a table for 6 to 8 hours develop severe mast
oh,
cell.
reactions, yeah.
Yeah. So, there's so many trade-offs. So you have to,
Mhm.
you know, which is the worst evil? I don't know.
Right.
People go back for second and third surgeries just for adhesion removal. So,
Mhm.
I don't know. I've had problems with adhesion scar tissue from open surgery. So, I don't know.
And Faye had some to add regarding folk surgery. So go ahead, Faye.
Hi there. So, my daughter, can you hear me?
Yes.
Yes.
Okay, great. My daughter we're going to be traveling there next week. I had a pretty in-depth conversation with him last month when we booked the surgery in regards to laparoscopic versus open. Because I am a nurse and because I worked for many years in surgical recovery, I know the pros and cons of both. I really wanted her to have it laparoscopic, and so I started looking elsewhere at the same time I was waiting for our appointment because I preferred that due to the scar that she's young. And he really reassured me why he does it the way he does it, which is open. And he stated on a more medical conversation that the the laparoscopic, he said, it's great. It's great for like a mouth surgery. Totally understands why you would do that laparoscopic. It's a no-brainer. He's had a lot of laparoscopic experience. He sits on, I think, the board of the hospital for laparoscopic surgery. He's, done over 15,000 of them. He said, he said he cannot understand how Dr. Showhead does it laparoscopic. He just said it's so complicated. All the directions you have to go to do that through a scope is very, very complex. He's saying, because I said, is that ever on the table? He said, maybe way down the road. He said, but at this point, with all the movement, he said you would have to go, and he kind of explained the angles, over this and under this to actually, to use the trocars to have visualization. So, he feels like, there's a lot of great surgeries that you can do laparoscopic, and this is not one of them. So that made me feel better about not choosing it, because I know there's a doctor in Florida that does it laparoscopically, or no, in Arizona as well. But he doesn't tack down the bowel. He just does the derotation. And he's a pediatric surgeon, but that's the only one. Obviously, there's not many that are going to do this at all, other than Showhead, that I could find. So he made me feel more comfortable, the fact that we are cutting, because I talked to him about the adhesions and my concern about that, because she's already had a mouth surgery. And he said, in regards to the adhesions, that it's not going to be much more of a deal, because you don't have to pass through all this tissue to put a trocar, to put the scope in.
Right.
So that made me feel better. And I also talked to him why, and as a bowel itself, the bowel is very mobile inside of your cavity where it sits. And my concern also was, tacking or not tacking down the bowel, and the bowel moving or twisting. And I said, my concern, I guess, with the tacking portion is, the bowel by itself in the cavity is typically free to move around. So if you tack it down, is that a risk down the road? And he said that the place where they tack it down, those places of the bowel, there's not a lot of movement in those areas. So that again made me feel better about, his decision to, to move forward and tack down the bowel.
Right.
And that's all I have. But just
Well,
to, make it clear between, laparoscopic versus open, and why. If he's a laparoscopic surgeon, he has no problem doing things laparoscopically. He does this by choice for those reasons.
Well, I appreciate those from a nurse's perspective, and we should, for full disclosure, Carolyn is also a nurse. So, so I think that she had, the same reasons that she was good with what she put her child through as well, and when you're a parent, as I was an adult, and, the decisions you make as an adult are completely different than when you make a decision for your child, it's, so I appreciate you giving us all of those reasons, and Dr. Showhead, we had a meeting with between all of the surgeons who do these surgeries, and, the Carolyn and myself and Tara, we listened to them talking, and Dr. Showhead was explaining how, he has to tilt the table, and that's why it takes, 6 hours with the robot and doing it laparoscopically, robotically, because to get the table in the positions that he needs to maneuver it.
Well, in a 6-hour surgery in general, there's more risk. There's more anesthesia, there's more gas, there's more, there's more room for issues when you have to keep somebody out for 6 and 7 hours. I'm sorry, Carolyn.
No, I was going to say, it just makes me think, with all that contorting around, does that mean that the patient's going to have more pain to deal with afterwards? That lengthy surgery. I that's my thought on it. But
well, and I also think about the EDS patients who are on the table for that length of time as well, because I think of all the people that I see with the severe mast cell activation syndrome after surgery, and 45 minutes versus 6 to 8 hours is a
It's a
lot.
big difference.
So I'm just, that's the mom in me.
So one of the quick little questions is the recovery time different between the two types of surgeries? And I guess even like comparing again laparoscopic to open to robotic and then versus DJ and the duodenal derotation.
I had DJ surgery, and I can tell you, I I was pissed off. Excuse me for all the kids in the audience, pissed off at my doctor. But the day after surgery, he came in and he said, "Get out of bed and start walking." Everybody who has surgery, you have to walk because it's important, because that's what wakes your bowels up. No matter what kind of surgery you have. If you lay
That's
in
so
that
true.
bed, if you lay in the bed, your bowels will not wake up because anesthesia puts your bowels to sleep. And everyone who's had surgery, raise your hand. Raise your hand. Anna, raise your hand. You had surgery. What woke your bowels up? Moving, right? Moving. So don't lay in the bed. Don't let your
Okay.
don't let your kid lay in the bed. Don't let yourself lay in the bed. Hate the doctor.
It
Hate your
helps with the
parents.
gas too. Best way to get that
Exactly.
take that gas they don't tell you about.
Yes.
Walk that gas out. Walk it out. I
Hate
mean, my God.
everybody. Hate everybody around you. Oh
hmm
well.
You can MF any person you want. They understand that you're walking the gas out. I was not a
Okay.
friendly person when that with that
No.
gas.
No.
So
No.
can you explain
Well,
how Dr.
maybe wait.
Alviar's
Nobody else got to answer the question. I just said about DJ
all
surgery.
right. I got
Anna?
lots of questions popping up,
Well,
Stacy.
we got 30 more minutes.
Damn it, Stacy. I sound like
Okay,
I
go ahead,
smoke
Carolyn.
20 packs a day.
Anna, you want to answer?
Sorry, what was the question?
Yeah, we forgot. What's
Um,
post-op like for
recovery time difference
recovery?
between like DJ or duodenal derotation, open versus laparoscopic or robotic kind of thing.
For me, I was in the hospital 5 days after my surgery, off pain meds, off the IV pain meds at 5 days, and I only took oral pain meds for like 2 days after that. Um,
She's a beast.
I'm not sure, like my mom said, I was using my gut before surgery. I found my J tube surgery, which was laparoscopic, to be worse pain wise than my derotation.
See,
Okay.
I was in the hospital, what, 6 days after for my DJ surgery. Went and had surgery on Monday, Tuesday, and got out on Saturday. Got out on, there was a
You got
football
out on
game.
Sunday because
Sunday,
they had
a
football.
football game. Tuesday to
Um,
Sunday.
so can you quickly explain like how Dr. Alviar's procedure, the duodenal derotation, helps with nutcracker syndrome?
I will say that there is a thought that because there were any of the surgeries that are removing the duodenum from the angle can relieve the pressures that the mesenteries are pulling on these things, and also give more room for the left renal vein. Now that's kind of there's a chance that that can improve. And for Anna, her symptoms went away, but they were not. Her nutcracker wasn't her primary presentation. Like I would say definitely her SMAS was. So in her case, it was probably mild. Um,
Yeah, so what happens is when they release the ligament of Treitz, they have to work at the SMA pedicle where the SMA connects to the aorta. So when they work at that SMA pedicle, it lets the SMA move a little bit more freely. So that supposedly will allow the SMA more freedom and it doesn't compress on the renal vein. The problem with that is
Yeah.
that
Yeah.
hearing a lot. The problem with that is that people with
Yeah.
like EDS tend to have more of a stretched renal vein and not a compressed renal vein. So some people that we're finding who think that they're going to get resolution of nutcracker syndrome don't. So it could be that, like Anna, she just had a true SMAS and nutcracker syndrome and not like more compressions. But people who have like the whole gamut of compressions, MALS, SMAS, nutcracker, May-Thurner, they may find that the nutcracker syndrome just, you find out that it's really, it presents itself as worse after surgery because everything else feels better. So that's what you're going to find. So
Okay, so how, sorry, let me go back down.
stay on task.
Does it matter at all if you've had auto transplant to resolve nutcracker, specifically with
first?
keeping the kidney on the left side?
With the kidney, a modified auto transplant, the kidneys drop down. Is that
I'm
what you're saying?
guessing.
So if you
Um,
have AT first, that's good because then you're going to move
Yes.
everything. Yeah.
Yeah. Shauna's recovering right now from an AT with Dr. Zendejas. She's about 10 days out.
Yeah. And both with COVID. So
And we got COVID in the
oh,
hospital.
God.
Oh, geez.
and we're rebounding today.
yeah.
He
that's
didn't
hilarious.
do your SMAS surgery?
No, she was being, she's been mouth feeding and keeping weight on through a PICC line and just eating a lot of ice cream and stuff. So he didn't want to do them at the same time. It was
Okay.
probably a good idea because her, the collaterals, and she had circumaortic left renal vein and she had an extra artery and had to do it
Wow.
all open and clean it all up. So it was probably a good thing. But he was able to drop the kidney down, but now the renal vein, he said, on all imaging here on out is going to look stretched. He said it's not compressed, but it'll look stretched on imaging.
Okay.
But don't worry about it.
And denervate with the nerve. So
Yeah, he
that's-
denervates the kidney too. So
Yeah, so that will stretch,
that
but
helped
not hurt
pain.
so much.
But I hear
Are you
that.
feeling good from that?
Yeah, I'm actually surprised. Yeah. It's
Good.
not been too bad. I'm trying to eat as much as I can and some solids and yeah. I'll
Okay.
get there.
But anyway, but
Yeah.
hopefully it doesn't change what DrFowlkes, does at
Yeah, that's
all.
what I'm worried about.
I wouldn't think so, but
I mean, there might be a problem if somebody moved it over to the right, but it sounds like it's there on the left. So
Yeah.
It is. Yeah.
yeah, our May-Thurner stent's pretty big. And then
Yeah.
what did he say? Your vena cava was shifted to the right, but he thought that might have been from the stent, but he wasn't sure. But anyway.
Radio.
You might, you'll probably be fine. You're tiny though, so, but probably everything inside is tiny.
Yeah, he said it was very,
Mhm.
EDS translucent and thin in our
Oh,
vessels and stuff.
Yeah,
So,
that was
Pretty typical, I think.
Yeah.
yeah.
Well, cool. Thanks.
Yeah. Thanks, guys. Yeah.
Okay, so many are diagnosed with gastroparesis as well. Does DrFowlkes do something for that too? And they're asking like anything with the pyloric valve or anything.
So, gastroparesis, again, you can't really tell. I mean, if you've had a lot of abdominal surgeries or you haven't eaten by mouth for a long time, you can't really tell how much of that's going to come back till after the surgery. I will say that there is no gastroenterologist here on staff within a radius of like 40 miles. That's, we're not a big hospital. So he does, there's no consult that you would have with anybody other than him. I mean, he would do, you can talk to him in your consult about whether he would check to see if you need a pyloroplasty. When you have the surgery, I mean, that can be part of your consult. And I'm sure he does do that. He will do, like, he will start people on some motility meds, and he does some of that just to get them, um, up and functioning enough to be discharged. But you really need to have somebody that's following you up, a GI at home that can, you know, deal with that if you're going to have some, it's going to be a slow return to motility when you get home.
Okay. Olivia says, I'm 22. I have HEEDS and MCAS. I also have MALS, SMAS, NCS. I also have 3 abdominal aneurysms. Can I expect weight gain to change my SMAS? What should be repaired first? Lap versus open? What procedure? So before we answer all those, the caveat is we can't give you medical advice. We can just, give you the information and you do with it what you please. So go
Wow,
ahead,
that's a
ladies.
lot. I'm scared to touch that with a 10-foot pole, Olivia.
I would say they definitely a vascular surgeon somewhere if you have the aneurysms. Would be the place to start about how safe some of these surgeries would be in that case.
Probably need a pre-op screening before you. I don't know. Aneurysms are always scary to me.
Yeah.
Some are safe. Like, oh, got a little aneurysm. But is a little aneurysm, or is it a scary aneurysm? With HEEDS, you never know. Everybody's like, aneurysm. 22 years old and it aneurysms.
Yeah, so like my advice would be once your doctors figure out what is safe for you, then revisit. Like the lap versus open would be more so of a surgeon's call to ensure your safety with that. And if they're good to go, my opinion personally is a duodenal derotation just because it alleviates that compression. But again, I don't know the medical side of it. I don't know, how having aneurysms could affect it. So that's something my biggest piece of advice is find a surgeon that you fully trust.
And
You don't even know where
probably
the aneurysms are.
be evaluated for vascular or classical aortic stenosis too.
Exactly. The
Let's see.
EDS.
Okay, she said no classical. Okay, sorry. I'm trying to catch up. How do you distinguish between the symptoms of MALS, SMAS, NCS, and GP?
How do you distinguish between them?
Yeah.
I would say nerve blocks for sure. If that helped kind of figure out what was hurting the most for me. I know everyone's so individual though. But oh, you're so young. I'm sorry.
Did you get a hilar nerve block? A hilar? Yeah.
Yeah, ended up doing hilar and celiac nerve block. Yeah, yeah, they both helped.
Oh, that's good. Yeah.
Yeah, good to know for sure.
A lot of journaling symptoms.
Yeah. Oh,
Yeah.
it gets a little. Yeah, I pity for anyone who reads.
Mal's is nerve, SMAS, more pressure compression. So sorry, while I was reading that, I might have missed your responses to that question of like how you differentiate MALS and SMAS and NCS. So um, forgive me if you've already said this, but it's really hard because even though MALS can involve the nerves, so does SMAS because you're having something crushed. And gut issues are both related because your celiac artery provides blood flow to your stomach and intestines. And so, if your intestines aren't working, is it because they're being squished or because they're not receiving the blood flow? So
Patient has GJ tube pre-surgery. Will Dr. Folks replace the GJ tube after surgery?
If you have a GJ tube going in, he probably will keep it. Now, what happened with two of the patients is their J immediately flipped after the surgery, so he just converted it to a G tube.
Okay.
But I if it's staying in place, it's not doing that. He probably will leave it alone. I would like to say something about one of the things that's been a challenge for this surgery is, and I noticed in that meeting with the surgeons, Dr. Show had said the same thing, is nutrition for the patients, because not everybody returns to eating in the same time frame. So, that's why Dr. Show he has that regulation or rule that he wants people on TPN and having a GJ tube before surgery, because it it's it kind of varies about how quickly people can return. Now, like Anna returned pretty quickly right afterwards. So she didn't have like a period of time where she was, other than a few days where she wasn't eating. Some of the patients, it's been pretty touch and go. Like one of them, I think it was like 10 days before she was starting to eat, and she had refeeding syndrome then after that. And then and one person he had to put on TPN, just because it was going to be the weekend and he hadn't eaten for like 7 or 8 days. So he started on TPN, and then that patient turned the corner like 3 days later and he was able to take him off TPN. So, I mean, there's a couple things that's why I really encourage people to do the absolute most they can to maximize your nutrition going in, because there's not a lot of cushion. If there's not going to be tubes, and if you're at a very lower weight, he very well may put a tube in during surgery just to make sure that, you can drain or start TPN. So, I always encourage people to do the most you can to gain weight or to try to maximize whatever you can get in before surgery, because every pound will help.
Right.
Because it's hard.
Yeah,
And
you
you
lose a lot of
lose,
weight.
yeah. You lose a lot of weight just from the surgery, and then there's no guarantee you're going to be going back to eating maintenance calories right after surgery. I mean, that's at least what, 1,500 to 1,800 calories a day. I mean, a lot of people, they're lucky if they can even eat 300 or 400 calories a day for several weeks after surgery, and that's if they don't, that's just from the swelling. And then if you end up having gastroparesis or you actually have some motility problems, it could be, several months before you're maximizing that. So it is, it's not a bad thing to have the tube put in. I mean, a lot of people say, "Oh, I want to come to Dr. Folks because I want to have no tubes," but doing that when you're really malnourished without tubes is scary.
Told Dr. Hong again.
Yeah. Like with my DJ surgery, I was NPO until I had upper GI with small bowel, just to make sure that my anastomosis was working. And then after that, they let me start eating, well, clear liquids. But this is way off the spectrum. People are producing bile and all kinds of crazy things that, we don't even see in the DJ world. And I don't even know why that is, but it's just odd.
Mm-hmm.
That I've had surgeries where I've had an NG just in an NG just draining, but that was just pulled, you know. So, if you don't want a tube through your stomach wall, you can easily say, I want NG in one nostril and an NJ in the other. If you don't want a surgical tube put in your stomach, put through your stomach wall, a surgical tube, you can do that. The NG tube is like, it feels like a tree trunk to me,
What's
but
huge? It's
yeah,
big.
yeah. But, some people don't want to have
Yeah.
another scar in their stomach. So that is that's perfectly acceptable if that's what you want. I understand, people don't like scars. So if you know, the scar, the surgical scar on those scars do very, they get better. And you can put, scar stuff on them and make them better. And the circle, the GJ scar is a round scar. It goes away once you take that out. Doesn't look so bad. Get a tattoo if you want. I don't know. I'm not a tattoo person, but some people have really cool tattoos for where their scars are. Put your hand down. She had she had has big tattoo because she had mastectomy, huge mastectomy. Anyway, so I understand, but there's ways to get around things if you don't want.
Anna, are you there?
Yeah,
Yeah,
Is
she's
Anna can tell you about her NG tube experience there because that's probably the worst part of it.
yeah, the NG was the worst. But for me it didn't last very long. It was very thick. Um, but yeah, that's that's all I have to say.
Yeah.
yeah. Well, I know when you wake up from surgery and you don't expect to have a G tube in you, it's like, what is that? A catheter is one thing, but this big in your nose, like,
And there have been a couple patients that really, really wanted that out, like very quickly, like we're adamant it must come out. And I can tell you that that's the best thing that's in there because you do not want all that stuff in your
yeah,
stomach. I mean, you'll just start be throwing up nonstop. It will be horrible. So it takes it off. It keeps the nausea down. It is uncomfortable. They do give you a spray that you can spray in your throat, and that does help. But you do want to make sure that's draining. I mean, that's been one of the things is you just have to watch the pumps to make sure they're not clogged. Ask the nurses, is this still working? Should it be flushed? Those kind of things.
yeah. Sorry, I was trying to read through these over here. Have you ever been told that having a feeding tube during testing that this could influence the results of your testing? Some people think that having like a J tube through the um, SMA aorta through that area will open up the distance or the angle, but I've known people who've pulled their tube just because they want a better reading, but you can pretty much tell if if there's going to be um, if you're going to get a diagnosis of SMAS. that tube is not going to make that much difference. I don't know. And for people who think that MALS is only nerve, some people don't have, some people will get a celiac plexus block and it doesn't work. That doesn't mean you don't have MALS. So don't think that if you fail a celiac plexus block, you don't have MALS. So, okay. I want everyone to know that. Just because some doctors in Connecticut say you have to have a positive celiac plexus block, that's not true. Don't tell them I said that though, because as I said that. I've had
Thank
two
you for
nerve
making
blocks.
me edit the video even
I
more
don't
than I
care.
already have
It's
to.
only in our block. It's only in our group. I've had 2 nerve blocks, but no relief at all. What does this indicate? It indicates that you're fine. You're not fine. Doesn't mean anything. There, I said it. What were the nerve blocks for? For MALS? Carsa? If they were for MALS. Oh, for MALS? Have you had a duplex ultrasound? Have you had the velocities checked?
MALS lap surgery that failed. CPBs.
Celiac plexus block.
Okay.
So, MALS surgery can fail and the mal can grow back. You can get scar tissue. The artery may not open all the way. A lot of times we see that a lot, even in like nutcracker syndrome. If the renal vein has been compressed for a long time, the vein is a vein. It's not an artery. Artery has pressure going through it. So you if you move an artery, it's going to have pressure through it. It's going to open, blood flows through it. You move a vein, it doesn't necessarily have the strength of blood flowing through it. It has valves. Those valves can be damaged, and no matter what you do, it's not going to open. You may have to have a stent. You may have to have the vein replaced. You may have to have something done to fix the vein. That's why they move the kidney so that the kidney's lower so that the blood goes up. But, I've seen people who've had surgery done and the vein never opens up. Just because you get it out from between that compression doesn't mean that the valve's going to open. Even if you put an external stent around it to protect it from the outside, the vein may not open. So there's a lot of reasons why surgeries fail, even a perfect surgery. The vein, things get compressed for so long, they just say, "Hey, can't do it anymore." And like,
Okay, Sarah says, my daughter has extreme nausea, bloating, fullness, difficulty eating and drinking because of nausea, constipation. Her pain is mostly her front left rib between the belly button and rib, and flank pain and back. But she has no pain increasing when eating. Do all of you or your kids have pain from the SMAS?
I was gonna say I actually had like no pain from my SMAS, just maybe sometimes like a pressure feeling around my belly button. But yeah,
And
not everyone has pain.
yeah, and her distance was only three millimeters, so it was more. It wasn't just constant vomiting for her. It wasn't pain.
Flank pain and back pain. So that flank pain and back pain is probably nutcracker syndrome, but the other pain is probably SMAS. So that's probably a great combination of SMAS and nutcracker syndrome. I can't tell you that because be giving you that's my opinion. But that's right where I have my pain. When I drink this drink, that's where I have my pain. Right now.
Sarah, do you have a question? I saw a thumbs up.
Maybe it was a thumbs up because she was agreeing.
Okay. I'm just double checking.
Parsa, you said you have very high velocities. So where do you live? Chronic constipation and GI dysmotility, a symptom of specific compression. Chronic constipation, well, that could be MALS or it could be SMAS. Dysmotility, oh, you're in Canada. Oh, Canada. Sorry. There's well, they're getting an SMAS doctor up there. That does Dr. Alvear's procedure. And I think there's a couple of good mouse doctors, but I don't know who does revision or
Do you know where
Doctor.
in Canada?
Yes. Yes, I do. But I can't tell you right now because my brain doesn't work. I can tell you. Give me a hot second to get on my phone, okay? Y'all carry on.
Oh, she said, "Hi, Stacy. It's Karina, not Sarah."
Oh, Karina. Oh, well, then you know who it is. She
The
knows who it is.
doctor's in Montreal.
That's right.
Hi, Stacy.
Hey,
Hey.
oh,
I
you're
just
on.
wanted. Yeah, I'm on my daughter's account. Sorry.
Okay,
So
fine. So you know who it is.
yeah, it's Dr. Gagne in Montreal.
That's right.
Yeah.
Yeah, experience is definitely lacking in Canada. I don't know if it's a lack of
No, it's not.
unwillingness to learn or
Well, they have doctors, but they have them scattered out. But it's just, people have a hard time getting to where they need to go.
right from Providence to Providence. Yes.
Province.
There
Not
was a
Providence.
question.
My daughter had the Strong's procedure. Now she has pulsating pain in her right side, but now she is eating. But she is eating still. Daughter had Strong's procedure, and now she has pulsating pain on the right side now, but she is eating. Do you think that her surgery failed or that something else is going on, Megan?
I'm just trying to get out of the pool. They think it failed.
Oh, okay.
I just wanted to know if any where they're getting a pulsating that will not go away.
Okay.
It's like the pains are between a 6 and an 8 all day, all night. And she's exhausted.
Thank you for joining us, Karina. Hope you have a good night.
Thank you. Thank you for everything.
Bye. So have you had more imaging done to know?
We're getting it done on the 20th of February.
Okay. That seems like forever away, doesn't it?
Yeah. I'm just getting a little worried about her mental health more than anything right now.
Yeah.
She just gets out of bed for about 4 hours a day now.
Oh boy.
Yeah. And she gets lots of migraines.
Well, migraines are sometimes more so related to nutcracker syndrome.
Nutcracker.
Oh, really?
Yeah.
And she's had migraines appeared right away before we were even diagnosed with SMAS. They thought she had stomach migraines. So maybe we'll be looking at that too then.
Yeah. I would.
But her compression was 6 millimeters and her angle's at 15. So.
Honestly, I would also check on the nutcracker
Okay.
because that compression causes reflux into the midline.
Okay. Okay. The Saskatoon doesn't believe that you can get more than one compression, so it's really hard here.
No, that's
Well,
terrible.
well, I don't know
Right?
why, because the renal vein and the
Yeah.
duodenum are in the same
I know.
place.
Yeah, every time I try to tell them that, they make me sound like I'm crazy.
I would say
Well,
almost
you are.
everybody here has Nutcracker and SMAS to some extent.
Yeah,
Sorry.
well, that's what I'm worried about. And she was doing physio, and our physiotherapist is saying that she's very flexible, like her neck and everything. So they're afraid that she has EDS. So we're trying to do that too, but our pediatrician has no idea how to do it.
So, how old is she?
She is 13 right now,
And where do you live?
Saskatchewan. Remember we were talking?
Oh, yes, yes, yes,
Yeah,
yes.
yes, yeah. I'm just having a really,
Oh,
really hard time
yeah,
with that.
yeah. Sorry, sorry. Yeah.
I'm
When I,
trying to make more awareness here. It's
yeah.
unreal. Just like we don't get any support here.
How did your thing go on Saturday?
Really well. Really, really well. Yeah.
Mm.
Yeah. And then it's called the online newspaper's called Saskatchewan Today. We just
Hmm.
did a huge article on Elizabeth and SMAS, and she's going to follow us all the way through
Oh,
just to
great.
keep the awareness out. So yeah, yeah, she's really going to help me push the awareness of SMAS.
Can you send that to us or send a link?
I will. I think it's going to be released tomorrow.
Oh, okay. Well, it'll
Yeah.
come in my Google alert
Hmm.
probably.
Yeah.
Great.
Yeah. We're trying, and then after I'm done with Elizabeth, the Saskatchewan government actually wants to talk with me because I've been pushing back really hard against them with the SMAS awareness and everything,
Well,
and we're trying to get Aviar to come up here, even if it's not my daughter, but somebody else.
yeah. Well,
Yeah.
if she has EDS, then the EDS Society will really help you somewhat. They'll help you. You
Yeah.
get,
I have just got connected with them on Facebook now too, which is good.
oh, good.
Yeah. And then there's my other daughter that's off and on. One question I do have about Mel's, I know you guys probably don't, I don't know how you guys feel about it. Does when it first starts, does it like come and go?
It, I don't really know.
Like I'm really worried about her because one moment she has a hard time breathing and it all hurts like in between her rib cage there, and then it goes away, and then it will come back. like months in between.
It could be like slipping rib. She could have slipping rib syndrome.
I feel like she probably has EDS too because she's constantly having to go to an osteopath as well.
Mm-hmm.
Yeah.
Slipping rib is part of Ehlers-Danlos as well.
Okay.
So you might look at that, but the poor baby.
Oh, it's terrible. And she gets vertigo all the time.
Mm.
She gets hit in the head and her skull plates are shifted to the point where her vertigo is back all the time. They get it from me.
Oh, you're so nice. My daughter gets her migraines from me, so
Yeah.
we all know what it's like.
Yeah, everything slips out of me all the time. So, oh, yeah, I just wanted to know if anybody else has
We're
experienced
all
the
hugging each
pulsating.
other. All the mommies are hugging.
Oh, it's the pulsating pain that I get worried about because the doctors don't understand it. All they want to do is give her nerve blocks in her small intestine and put her on pain management.
Well, that pulsating pain is just her aorta, probably just because that's the biggest artery in your abdomen, and it just, especially if she has POTS or anything, it's just gonna go crazy when you're having, any sort of
Yeah, and she says
POTS.
that eating now doesn't seem to bother her. It's just the steady pulsating pain that is exhausting her.
Well,
So I'm a
hopefully,
little worried on what the CT scans are going to say, if she can be fixed or not. No.
hopefully we can get it all sorted and
Yeah. We speak with Gagne, Dr. Gagne, at the end of February after his CT, so hopefully he can give us any answers.
yeah.
Yeah. Yeah. And then hopefully we've raised enough money that we can get there.
How much do you need? Because
I have no idea yet. He hasn't said anything because he has to look at all of our images first, and Saskatoon are procrastinators, and they sent it the day before our appointment, and it should have been there like a week and a half before that.
oh boy, okay.
Yeah. So I'm not too impressed with them at all, but their understanding when a mama means something, they mean it. They know when I'm calling that they got to get this done. I don't even let the doctors say anything. I just tell them what to do at this point. But I gave them enough information that they had no idea. Half of the stuff that Aviar said in his webinar. So a lot of information needs to be, I don't know. It's like they don't want to learn. Does that make sense?
Yeah.
Yeah. Or frantic, angry. But I'll let you guys be.
Come on, where did you go?
Did you want me to keep talking? Because I can. That's the only question I had was about the pulsating pain.
Going to see my chat. Sorry. Stacy's having a problem. Well, does anybody else have? I mean, this was supposed to be about DrFowlkes, and I don't know that we really got very far with that. So, Did anyone have any questions? Problems with getting a hold of DrFowlkes, having a meeting with DrFowlkes, anything that we need to share about DrFowlkes? Staff problems? Getting there, anything you want to know about the hospital? Anything Carolyn can ask you? Faye.
Just that it's a small hospital and, they're doing the best they can. This is, you know, th- they're feeling I think the staff is a little bit overwhelmed and, patients come, I think, maybe they're desperate and they maybe have different expectations that this is a big city hospital. It's not. So we just show some grace for the nurses. They really are trying.
Yeah. I think that's important for all of us to remember. Faye, did you have anything you wanted to say? She's on mute. Can you unmute her, Tara?
I think I have it. Are you there?
Yeah.
Oh, okay. I just going through this process. I would always say for anybody, make sure to schedule in advance an appointment with him to touch base maybe a couple weeks before your surgery, because we're kind of doing it at the last minute. And I know he is probably scrambling because he's so busy. So maybe set that up in advance of your surgery, maybe a couple weeks, just to tie up any loose ends. And also, I think there's a little confusion, maybe looking for some clarification for others as to when the surgery scheduling team calls you to let you know your surgical time. Kayla told me it's the day before. I've heard it's the week before. I don't know if there's a clear-cut answer on that one. Maybe you can enlighten DrFowlkes on that.
Okay, we'll try and figure that out. I know,
Okay.
I think like there's 3 people on this next round, so there's probably, they'll probably, my thought is the youngest person will go first, then the oldest person or the most,
There she
usually,
is. You're wrong way.
usually the youngest person goes first.
Okay.
And the oldest person goes last. I know that's usually how it goes.
Okay.
So, and it's usually like the most complicated person that I don't know, Carolyn, do you know?
I don't know. I think some of it depends on how long they anticipate the surgery will be. So usually he tries to do like 2 in the morning and then 1 in the afternoon. So maybe the more complicated one goes in the afternoon.
Right. Yeah. So, and you guys all know who you're all going together with.
Right.
So it's not like I have to say names or anything, but so probably the old lady will go in the afternoon because she's the most complicated person. And the younger people will go in the morning. But, it also, if Dr. Alviar is going to be there, part of it's going to be like, plus it may not only be you 3 people,
Right. There'll be other people that day.
right. So, and, Dr. Alviar might need a snack.
Right.
Because
he may not want to stay up till 5 p.m. to be
no,
operating.
no. And he's funny because he'll text me and he'll say, "We're done. It went really well." I'm like, "This is HIPAA. Why are you texting me?"
Well, he
'Cause
said we're done. He didn't say who it's done. He just said we're done.
No, but he knows that I know everybody because everybody usually posts. No.
He came before HIPAA. HIPAA doesn't mean anything to him.
Oh, nothing means anything to him a lot of times because he's posting everything about everybody and he's like, we're all part of SMAS nonprofits like, Dr. Alviar, have you ever heard of HIPAA? He's like, what? Okay, so Carsa, Dr. Alviar is not always there. If you wanted Dr. Alviar to come to a surgery, you have to contact him, and then wherever you are, you talk to him, and then he work it out with him to see if he can come. And Monty, Dr. Alviar is retired. He is 83 years old. He still has his license to practice. He's retired from University of Pennsylvania Medical Center in Harrisburg, I think. And so he's our medical advisor for the SMAS nonprofit. And somehow, I don't even know how the hell this all started. He's, yeah, I do know how it started. Dr. Showhead read his research article and called him up one day and said, "Hey, can you come out here and show me how to do this surgery right?" Because he thought he could read the research article and just wing it. And I kept telling everybody, don't read the research article because that's not how it's done. There's more to it. Nobody would believe me because I know Dr. Alviar, and he told me. So anyway, finally said, I got to get him in the surgery in the operating room with me to show me the correct way. So that got him involved back in the operating room. And since then, he's been just traveling around. New to all this, so don't know names, etc. Yes, now that you're not new, you've been baptized by fire, so now you know. Yeah, in the Facebook group, you'll be
You did
seeing
miss, yeah, see, you missed that question earlier. How long is the wait to get a virtual appointment?
it. It just depends because, as you know, he only in the office on Wednesdays and Thursdays, and he makes these appointments after hours. So I don't know how many people are waiting in the queue, but right now we are trying to get a doctor on board in Texas. So I'm trying to find people who are willing to climb up on the table and be the first person to have surgery in Texas with another doctor that Dr. Alviar wants to train. And then that'll open up a whole, that'll give some breathing room for DrFowlkes, and we can get some people into Texas to also have surgery. And then we have a guy up in Michigan, but he only wants to do one surgery and see how it goes, and then he'll start taking patients.
Well,
But he
that's how
already has.
Dr. Folks started too. He was going to say, we'll see how it goes.
And then Anna was like, "Yay, look at me!" And then then it happened. And so, that's why, like, my guy in Texas, I don't want to say, like, I have Dr. Who's What's It's in Texas, and he's ready to go, but I just need somebody who's brave and wants to be the first person. And the guy is, he's an excellent surgeon, and Dr. Alviar knows him and has gone on mission trips with him and everything. But,
And
I
can I
just,
can I comment on that? Because my daughter was the first patient for, and I want to say this isn't like having a student resident or something operate on. This is like a doctor. These doctors they operate all the time in this area. They do these surgeries that are similar. So this is just learning. They already know a lot of the steps of the procedure. It's just learning the right order and why, the rationale. So
right.
it's not like you're getting some novice to do it. And I actually think
Okay.
I think it was great because Dr. Folks was like so razor sharp, so focused for this. He'd done all the research, he was like so on board. And I can't think it went like clockwork. I just can't think of anything better. So I think if you've got a great surgeon that's willing to do this, and you've got Dr. Alvion involved, it's a great opportunity.
So yeah, like our Texas guy is like, he is a professor at one of the medical schools here in Texas, and he's I could go on. I could tell you a lot of stuff that he
Mhm.
does, but then you might figure out who he is. And I don't want people saying, oh, it's Dr. Whoosy What's It. That's how I'm sketchy. Sorry. I was called sketchy in another group because I wouldn't tell people what his name was. So
But
maybe.
you digress.
I know, I'm just digressing. I could tell you who he is, but then I'd have to kill myself. All right.
Don't make me drive over there.
How do you say folks? Folks. Is that what you wanted, Faye? How do I say folks? That's how I say it. Is that right, Carolyn?
Yeah.
Folks?
Mhm.
Howdy, folks.
I thought it was Fowlkes. I just want to make sure I don't call him the wrong name.
No, it's folks.
Okay.
You don't want to seem silly, right?
What's that?
You didn't want to seem silly.
I don't want to call the poor guy the wrong name. He's doing enough. It's not, I don't want to butcher his name.
You just want to say doctor. Hi, doctor.
Right. There you go. That'll work.
Folks.
Folks.
Folks. Yes. My wife's the med encyclopedia on all of this. Oh, yes. Monty, you've got to get on board. You gotta read it. All right, any other question? Oh, Monty's typing. Oh, he's trying. Okay. There'll be a quiz at the end of the day. Jennifer, glad to see you here. That it? This has all been very helpful, encouraging. Thank you, Monty. Thank you, Faye. Thank you, Tara, for joining us on your night off.
I haven't had today off at all. Who are we kidding?
I know.
Thank you, Carolyn, for
Thank you, Carolyn.
always
You're
having
welcome.
your wonderful insight and medical knowledge. And so,
Thank you all
all
for
right.
hosting this.
Thank you,
Thank
everybody.
you.
Okay.
Have a good night, guys.
Bye bye.